Thank you.
Thank you very much, Professor Taro. The last speaker in the session is the Professor Feitosa from Brazil, stem cell therapy in heart failure.
Dear Chairman, ladies and gentlemen, once again I want to thank the organizing committee for this kind of invitation that will allow me now to talk to you about stem cell therapy in heart failure. I have no conflict of interest regarding this subject. And let me remind you that when the patients with heart failure reach a very severe situation, such as Class 4 New York Heart Association functional class, the survival can be measured in months, as was well shown in the first consensus trial. See, even if he was taking the best medication at the time, enalapril, the survival could be measured in a few months. Even worse, if a patient reaches a situation of cardiogenic shock. And then we can measure the survival in days, such as can be seen here in the shock trial by Judith Hockman. Therefore, patients with heart failure, advanced heart failure, they have a very limited prognosis. In this situation then, the possibility of reversing what Professor Hoare detailed for us in a very comprehensive way regarding remodeling, an experimental example of which we can see here. This is a situation in which, in a mouse model, the rect had a reperfusion after 2 hours occlusion and ended up like this. And in the other situation, the occlusion was not undone, and the patient, the rat went on with the total occlusion, getting a much severe kind of remodeling. This can be seen in humans. This is an echo study of someone who has 1 week after an infarction of an arterial wall MI, and the same patient now remodeled, and now 3 months later he has a much worse situation. Professor Hoare told us the details of this remodeling, which involves cells, cytokines, fibrosis, apoptosis, and loss of a lot of cardiomyocytes. Well, in this situation, the possibility of replacing the cardiomyocytes is very attractive. And that's when the attention turned to the possibility of cell therapy. And the thought was to be able to take some cells, to inject or to make them come to their heart somehow, and make them replace the cardiomyocytes and remodeling in a remodeling process. This has to do with stem cells. As we know, the zygote gives rise to the pluripotent stem cell. A few weeks after the formation of the blastocyte, the inner cell mass will give rise to these cells, which are the embryonic stem cells, and they can form any tissue, any cell in the organism. The application of these embryonic stem cells in clinical therapy has faced many ethical issues, and it has not been done so far. So the attention turns toward the pluripotent somatic cells that are stem cells that reside in the organs, the CNS, the liver, skin, mesenchymal, and others, the heart included. But because of the easiness of acquirance, all the attention has turned to the blood cells, either harvested from the bone marrow or else taken from the blood circulation after stimulation by GSK, for instance, for some cytokines. And most of the studies done so far in humans have utilized this. All of this started with the work of Piero Anversa in New York, and this is the very first one done in an experimental animal. So after myocardial infarction done in mice, the injection of those cells taken from the bone marrow, they demonstrated it was possible to regenerate tissue within the scar tissue. And this is the first proven demonstration of the possibility of regenerating cells in the scar tissue. That brought on a lot of enthusiasm regarding the subject, and especially when other studies such as this have added strength to the concept. For instance, in this study, in a dose-dependent fashion, like in a pharmacologic drug testing, stepwise increasing in the amount of cells that were administered demonstrated in comparison to the control, a significant improvement both in anatomical and functional modifications of the experimental animal. So the enthusiasm was clear, and that's when we did in our experimental group, we did in a Chagas model of a Colombian strain of Chagas disease, in mice of Chagas disease, that resembles the human cases when the animals are sacrificed somewhere around 6 months and 1 year later after the infection. In animals such as this, the administration of bone marrow cells was capable of reducing, as compared to saline, the inflammation and the fibrosis. This was measured, it was very impressive, so everyone was very enthusiastic about this. That's when came the first work done in humans, and the first publication came from Bodo Strauer in Germany. This is the case of in which intracoronary transplantation of autologous mononuclear bone marrow cells were performed in a number of patients with MI, and apparently without any damage, and apparently with some benefit. So this was the very first study, 2002, that gave rise to many other studies that we see nowadays. The routes that have been utilized for stem cell implantation have been very many, but mostly intracoronary. But surgically, it could be via epicardial injection and by catheterization via transendocardial fashion. But mostly they are utilized through the coronaries, injected into the coronaries. We were allowed by the institutional ethical review committee of our hospital and national committee, we were allowed to do in our group a pilot study in Chagas. So that's when we did a prospective, single-center, open-label, non-randomized, phase 1 clinical trial. The idea here was to see the feasibility and safety and potential efficacy. 30 patients with advanced heart failure due to Chagas disease were subjected to the study, and we had a 180 days follow-up. These patients had these characteristics. They were very severely affected by the Chagas disease. Although they were stable for over a month, but stable in New York Heart Association functional class 3 and 4, with the best standard heart failure therapy. They all had ejection fraction below 40, both genders, and between 18 and 70 years. So the iliac crest was punctured, bone marrow was harvested from there, and an amount was taken which was filtered, purified in a proper fashion, and after that it was injected into the coronary. This is the way that the procedure is done. The mononuclear cells that are the cells of interest, they are easily recognized in the tube. The blue trypan viability test showed viable cells in 98 to 100% of the cases, and they were injected into the coronaries, 10 mL in the anterior descending, 5 mL in the circumflex, 5 mL in the right coronary arteries. The whole procedure usually took from 2 to 2.5 hours. Those are the results. So in this self-controlled results, the patient was his own control. This was the design, the methodological design. In this design, the results were very impressive. So there was an improvement in functional class, there was improvement in quality of life, and there was a strong tendency for improvement in left ventricular ejection fraction. But in order to have a new intervention, we have to compare it with a group, not with the patient itself. And preferably, this should be done in a randomized way, blinded if possible. And as this is an experimental work, it should be with a sham procedure if possible. That's what we did. We proceeded now then for a national study on Chagas disease, which included many investigators from many places from Brazil. This study was sponsored by the Brazilian Ministry of Health, and we did that in a prospective, multi-center, randomized, double-blind, and placebo-controlled study. All patients went to the cath lab. All patients had aspiration. They all agree with that. Nobody knew who was taking what. And not even the one who shot the medication, the cells, knew what he was doing, because a special paint was put in the serum so that nobody knew what was doing. It was a double-blind. The primary endpoint was changing LVEF at 6 and 12 months. And safety endpoints were evaluated, and all patients had been in optimized therapy. I should like to call your attention to the fact that these patients were very severe. These patients had an ejection fraction of 0.26. These patients were very dilated. They had an LV diastolic dilation of 7 centimeters. So the end systolic internal diameter was of 6 centimeters. So they were very dilated, poorly contractile ventricles. Well, then these patients were treated as indicated, and those were the results. Both at 6 months and at 12 months, we did not see any difference in ejection fraction. We didn't see also any difference in the Minnesota quality of life, walking test, neither in mortality. And we concluded then that under the current technique, the technique we applied, the intracoronary injection of bone marrow-derived mononuclear cells did not provide any measurable benefit for patients with advanced Chagas disease. This is representative of the patients we studied. They were very severely, that's how we were allowed to do. The ethical committee only allowed us to do in a very severe case of Chagas disease. And we understand that. But then that's Chagas. And we stop here for Chagas for the moment. How about the ischemic cardiomyopathy? Let's take a look at some of the old studies from Menachet, from France, and many others. Bobostal, Perrin from Rio de Janeiro in Brazil, Perrin from Texas, and he's a Brazilian working in Texas. In small number of cases, no randomized, nice results. But this is not the correct methodology. How about going to the controlled clinical trials in ischemic heart disease? If we pay attention only to those, that's what we see. We see that these patients have these characteristics in papers that were published up until 2006, so 8 years ago. What we see is this. What we saw was a modest improvement in ejection fraction in controlled study. So there is something there. But as far as ejection fraction goes, the results are modest according to those studies. The clinical benefit in those studies were only apparently a diminution of recurrent myocardial infarction. There was no benefit regarding death, nor target vessel revascularization. There was a tendency for diminishing rehospitalization. Now, let's pay attention then to some of recent studies, very recent ones. Let's see the time study. In this time study, the authors in ischemic heart disease, acute myocardial infarction, they set up a protocol to see whether one should do it early, after the angioplasty, something like 3 days or 7 days. And in a randomization 2-to-1 with cell-free, so adequate control, they compared the results. The results were, unfortunately, in this study, the results were negative. They did not show benefit from ejection fraction. Well, how about the Swiss MI? The Swiss MI comes from Switzerland, and again, tested in individuals who received the bone marrow cells 5 to 7 days or 3 to 4 weeks and compared it with control, and evaluated 4 to 12 months later. And the results of the Swiss MI, the results were negative. So there was no improvement, no significant improvement really in ejection fraction. We saw early this morning the enthusiastic presentation of Professor Byung regarding the utilization of another type of approach, which was from the progenital cells in his program of magic stem cells. Looking at that program, we see that there is something, of course, to be pursued regarding stem cells. But I would like to bring to you another vision that seems to be another way of doing it that seems to be very promising. And this is the CPO trial. This is a peculiar trial that was recently presented, included patients with less than 40%, a history of Q-wave MI with a residual scar. These patients had to be candidates for surgery, and they were led to surgery once they had proven the presence of a scar, and once in the operating room, they had part of the right atrium taken out, and their cardiac stem cells were identified, they were expanded, and later on they were applied to the patients, and they were followed, and the results were positive. The results, in comparison to a control group, the results of was a significant increase in ejection fraction. But that doesn't surprise me, that doesn't strike me that much. What we were very impressed with this. We were impressed with the real demonstration of disappearance of scar tissue. So this is the first time that this is proven. So the scar tissue disappeared with cardiac stem cells. Well, that shows to us that yes, there is something to pursue regarding stem cells in the context of ischemic heart disease. There is a lot of work to be done. It's necessary to enhance differentiation of whatever cell we choose, enhance the cell number, enhance the mobilization in homing, and enhancing cell function. There is a lot of work to be done regarding this. Many cells are being studied for that end. Mesenchymal stem cells-like populations from adipose tissue, heart, dental pulp, peripheral blood, and others. And I think in this moment, most of the attention turns to this cell here, the induced pluripotent stem cells, iPSC, because it resembles, it tends to resemble the embryonic cells, not being an embryonic cell. So there is a lot of hope considering this kind of cell here, even more than the cardiac stem cells. So, ladies and gentlemen, I would conclude by saying that in ischemic heart disease, there appears to be a possible role for cell therapy. Future developments in this area, such as refinement in the cell type and cell delivery, are eagerly waited for. Thank you for your attention.
Thank you very much. Couple of questions, maybe within 2 or 3 minutes. Any questions? Please.
So I think we all learned that mononuclear cells are not helpful as far as improving the function. What about the mesenchymal cells? Have you any experience of using mesenchymal cells in some of the patients?
Okay, there have been many studies using mesenchymal stem cells. They are a little bit more difficult to handle. Their expansion is not that easy, but again, the results are in the mixture of what we see. If the route is the intracoronary one, and that's what's mostly used. I think the great hope right now is to get a better type of cell, and I think the iPSC is a great promise, since we are absolutely unable, and I really think we should not pursue that direction for utilization of embryonic cells.
What's your explanation for the disappearance of the scar?
It's not an explanation, it's a hope. And the hope...
No. Based on the picture you showed.
It's a hope. We hope that has occurred because of replacement, cell replacement. But we still have to go a little bit further and mark the cells and see if that's the case. So I would say that it's a big hope. But that was never seen though before. The scar disappearance has never been seen.